Good evening, ladies and gentlemen. Let me welcome you all with warm hands on behalf of Ceylon College of Physicians. It's the beginning of a new chapter. Ceylon College of Physicians proudly introduced the program of peer learning with international faculty, which creates an innovative learning platform to share the knowledge and learn through experiences. Today, we have the inaugural lecture on when to intervene in acute coronary syndrome by Professor Azfar Zaman, professor and interventional cardiologist from United Kingdom. For the speaker introduction, I cordially invite Professor Arosha Disanayake, the President, Ceylon College of Physicians. Over to you, sir.
Right. Thank you, Disna, for the starting of the proceedings. And it is my great pleasure to welcome all of you for the first in the series of peer learning from international faculty series of lectures. The idea is that throughout this year, we will have a lot of peer learning from physicians, non-physicians, local people, overseas experts, physicians who work in the peripheries. So, because peer learning is probably one of the most important ways that we can actually share knowledge and learn from each other. And with that in mind, every month we will have peer learning from a person of academic eminence, speaking to the members, fellows, and of course, associate members, trainees in medicine of the CCP. And it is my great pleasure today to welcome today's speaker. He has kindly agreed to spend 1 hour with us. Professor Azfar Zaman, professor and interventional, he's a clinical professor of cardiology and consultant interventional cardiologist. He's the director of the Cath Lab's head of transcatheter interventions in the Freeman Hospital, Newcastle upon Tyne, UK. His research interests are in thrombosis and acute coronary syndromes. He has published over 120 peer-reviewed papers. And very importantly, he has been the principal investigator for over 50 clinical trials in management of acute coronary syndromes. And he has been the chief UK investigator in 10 such clinical trials. And considering the audience, he has chosen for us a topic which is very, very important to both cardiologists, because every time we see that, we know that the vast majority of patients with ischemic heart disease are seen by, not by cardiologists, but by other doctors. And every time we see somebody with ischemic heart disease, we need to make a decision as to whether we need to refer this patient to the interventional cardiologist for intervention. That's an important decision. And I'm sure this lecture will go a long way to clear our doubts and also give us some direction as to who, when should we intervene or plan for intervention or refer for intervention of patients with ischemic heart disease. So with that introduction out of the way, it is my great pleasure and privilege as the president of the Ceylon College of Physicians to welcome and invite Professor Azfar Zaman to do. And at the end of that, we will get some really good quality time to have a Q&A session to develop the discussion further. And I invite all of you to take part in that discussion. Over to you, Professor Zaman. It's our pleasure to have you here this evening. Thank you.
Thank you, Arosha, and thank you for that very generous introduction. So just technical aspects first. Are you able to see my slide?
Yes, we are able to see. Yes.
Okay, well, thank you very much. So I have been involved with my friends in the Sri Lankan cardiology forum, and I'm aware that the numbers of cath labs in the country has increased enormously over the last 10 years. So what this talk does now is I'm going to try and present to you which patients now should be using the facilities that the country, the government has invested in across Sri Lanka. So the title of the talk as the introduction is in non-ST elevation acute coronary syndromes, non-ST MI, when should we intervene? And I'm going to talk about timing of invasive therapy and, importantly, the evidence from randomized controlled trials, because most of you will know that all interventionists, when you ask which patient should go to the cath lab, they will see everyone. So what is the evidence from randomized controlled trials that determine when and who we should take patients? After this evidence, I will talk about guidelines from the ESC from 2 years ago. So for those of you who are not in cardiology primarily, it's important, I think, that we all understand what is the spectrum of acute coronary syndromes that we are dealing with. So these are patients who typically are admitted with ischemic sounding chest pain. And then based on that, you have a working diagnosis that they may have acute coronary syndrome based on ischemic sounding chest pain at rest. That is the key thing. They then go on to have a 12-lead ECG, and based on that 12-lead ECG, we make a working diagnosis if there is persistent ST elevation, that they have ST elevation myocardial infarction. These patients go immediately to the cath lab as soon as possible for primary PCI. I'm not going to be talking about this group. The next group is those with persistent ST or T wave abnormalities and with a troponin that has raised and then fallen within the space of 1 to 3 hours. These patients, if they've had a biomarker troponin rise, are said to have had a non-ST elevation myocardial infarction. You can also have patients who present with acute chest pain at rest with normal or undefined ECGs where the troponin is normal, and these patients have unstable angina. Having qualified this, we now need to work out which patients, as I said, STEMIs go immediate, but which of these other groups go to the cath lab and when. So what is the scale of the problem? So this is data I'm going to present to you from 4 nations that tells you that even with optimal therapy of acute coronary syndromes, and this is from Sweden, France, US, and UK, that even with optimal treatments, immediate post-MI, and these are non-STEMI and STEMI survivors, that in the 1-year follow-up, approximately 18.3, nearly 1 in 5 patients have a cumulative 1-year incidence of cardiovascular death, MI, or stroke. If you then focus on the near 82% who are event-free in the first year, and you follow those patients up for the following 3 years, the cumulative 3-year incidence of cardiovascular death, MI, or stroke is once again 1 in 5. So even with optimal medical therapy, optimal interventional therapy, there is a high attrition rate over 1 year and 3 years. So it is absolutely important that when we have these patients presenting to us, that we treat them appropriately with the right medication and the right interventional therapy. And this talk will talk about the correct interventional therapy. There are lots of factors that have led to a decrease in deaths over the years. And this is a paper by Ford et al., which is old, but essentially what it says is that 47% of our reduction in deaths are due to therapies that we entertain at the time of admission, and that risk factor modification leads to a further 44% of the reduction in death. So how can we risk stratify patients in ACS? So also, I want to make this clear to our non-cardiology audience that when we assess risk, there are 2 types of risks that we talk about. One is the mortality risk when patients present with acute coronary syndrome, and this is different to assessing the risk on patients who we refer for early invasive therapy. And it's important for the audience that you understand this. So what I'm going to get out of the way first is what all of you will be aware of is that the different risk scores that exist for assessing mortality and events. And the most common of these is the GRACE score. And sometimes we use the TIMI score, but the GRACE score has been undervalued now in the latest guidelines, but it's what is common for assessing mortality. And the reason why it's important is that using this risk score, you can assess the risk of in-hospital death here in the top box, and also the risk of post-discharge to 6-month death based on low, intermediate, or high GRACE scores. Now, I'm not going to focus on this because this is what you're familiar with, but I want to use this to highlight that there is a registry for assessing risk of mortality, both in hospital and at 6 months. And I imagine that all of you have availability of this. It's available as an app on your smartphones. And also there is the TIMI score, which we used around 10 years ago, but has fallen in favor. But essentially, you can also do the TIMI risk score, which assesses all-cause mortality, MI, and recurrent ischemia, and urgent revascularization for up to 14 days after randomization in this trial. And you can see that the higher your TIMI score, the higher the risk. So once again, I want to emphasize that you have risk scores for assessing mortality and morbidity after an acute coronary syndrome. But what I'm going to focus on is risk score for early intervention. So what do we do when patients come in with non-ST elevation acute coronary syndrome? Okay, so this is very clear. In the first time of admission, we measure their high sensitivity cardiac troponin. If it's very low, we say that that patient has been ruled out of having an infarct, and we have the option of discharging early with the other option of having a stress test or a coronary CT at a later date. If the troponin, high sensitivity cardiac troponin, is high, that patient is said to have a rule-in for acute coronary syndrome. That patient will be admitted to CCU and they will undergo angiography and/or echocardiography. And this is the group that I will focus on in my talk. There is this middle group where there has been low troponin rise, where you may wish to observe them for a further 12 hours before deciding on whether you want to do outpatient angiography. When we talk of invasive treatment for non-ST elevation acute coronary syndrome, we are talking about two strategies. We either go for routine invasive strategy, or we go for selective invasive strategy, and they have different meanings. Of course, all these patients will have optimal medical treatment. And what I'm going to present to you now is clinical data to show whether routine invasive strategy is better or selective invasive strategy is what we should be going for. Now, let me resume slide soon. So routine invasive strategy, as its name suggests, is that all patients, when they're admitted for hospital with a diagnosis of NST-ACS, all undergo invasive coronary angiography on admission. When we talk about a selective invasive strategy, we're talking about patients who go for invasive strategy if they're deemed to be very high or high risk. And I will define what we mean and how we define very high and high risk. If they have recurrent symptoms, so the patients may have come in with low troponins, but they have T-wave inversion anteriorly and they've had recurrent symptoms, this patient should go for early invasive strategy. If they have objective evidence of inducible ischemia on a stress test or a stress MR, or if they have detection of significant obstruction on a CT scan. So before we decide how and who, what do the randomized control trials tell us about intervening in non-ST elevation myocardial infarction? For ease of giving you this information, I've divided the randomized clinical trials. I'll just do 2 to 3, and I've divided them into those trials that collected short-term data, and I've arbitrarily defined that as less than 5 years, and those that collected patient data for up to 10 years. Because when we talk about intervening in patients, managing our patients, we want to know what is the outcome benefit short-term and long-term. So this is the first study that I'm going to talk about. And this was a study, the Riddle non-STEMI study, which was looking at immediate versus delayed intervention. So these are all patients who'd been admitted with a diagnosis of non-ST elevation myocardial infarction based on a chest pain of a duration of less than 24 hours, and most of them had troponin. 162 patients went for immediate angiography, and 160 when it was less than 2 hours. The delay was anything up to 61 hours. And the primary endpoint at 30 days showed a significant benefit for those who went for immediate intervention. And the conclusion of the authors was that immediate invasive strategy was associated with superior outcomes at 30 days. If we look at the verdict study, which was a prospective 2-centimeter randomized control of larger patient cohorts of over 2,000, once again, if you look at the very early group versus the standard group, in this study, they found that very early invasive coronary angiography, so a median of 4.7 hours versus a delayed approach, did not improve long-term clinical outcomes, and the follow-up was for just over 4 years. So you had these different studies showing quite different end results in these patients. If we then go to the early study, which was once again a smaller 709 patients, and these were 363 high-risk patients who underwent coronary angiography at 12 to 72 hours, and they divided them into high risk and very high risk. And the very high risk underwent coronary angiography within 2 hours. And this was the first study that showed that if you risk stratified patients into high risk and very high risk, that very early invasive strategy was associated with significantly fewer events compared to a delayed strategy in patients presenting with non-ST elevation ACS. And this was the latest study that we have that presented in such patients. This was presented in 2020 and supported the risk stratification and the very early invasive strategy, i.e. within 2 hours in patients defined as high risk. And we'll talk about how to define high and very high risk. What about studies that looked at long-term data? And once again, this is my definition of beyond 5 years. So if you look at the Ictus 10-year study, which was presented in 2017, 1,200 patients, 604 had early invasive and selective invasive in just under 600 patients. And vital status was known at 10 years in over 96% of patients. So in the Ictus study, early invasive strategy of patients without selection had no benefit in terms of 10-year death or spontaneous MI compared to a selective invasive strategy. So in one patient, all patients went for intervention. In the selective invasive, only certain patients went for PCI, and there was no difference at 10-year event rate. The FRISK-2 looked at event rates at 15 years. 2,457 patients, equally divided between invasive and non-invasive. And this was a seminal study because what it showed was that patients in the invasive arm for non-ST elevation MI, that an early invasive strategy postponed the occurrence of death of further MI by an average of 18 months compared to a non-invasive strategy. And this was a seminal strategy because it was the first study that really told us that in these patients with non-ST elevation MI, in the high-risk patients, there was no role for an optimal medical therapy alone. So if these patients were high risk, that they benefited from invasive strategy. And I'm going to just show you the last study, which was about the timing of intervention, which was the TIMAC study, which is over 3,000 patients with non-STEMI and unstable angina. One arm had routine early intervention and the second arm had delayed intervention. The routine had coronary angiogram within 24 hours. The delayed intervention had coronary angiography beyond 36 hours. And the primary outcome, the hazard ratio in the early intervention group, was no different to that in the delayed group. And the primary outcome was a composite of death, MI, or stroke at 6 months. If you look at secondary outcomes, death, MI, or refractory ischemia at 6 months, there was a relative reduction of 28% in the early intervention group. And using the pre-specified analyses, the early intervention group improved the primary outcome in a third of patients who were at highest risk. So what the TIMAC study did, once again, an up-to-date contemporary study, what the TIMAC study did was confirm two things. One, that you had to select the highest risk patients. And once you did that, then these patients benefited from early intervention, which was defined as intervention within 24 hours. So you have to then apply this to your practice, where you practice, whether it's in a hospital with a cath lab or without a cath lab, and you have to change the system to identify patients at high risk and then make sure that they have routine intervention if they're deemed at high risk for these patients. So what the meta-analysis tells us is that they do not reduce all-cause mortality risk in the overall population of non-ST elevation ACS. They can increase the risk of periprocedural complications, but they reduce the risk of composite ischemic endpoints. And I want to emphasize, particularly in high-risk patients. And if there's one thing I want you to take home from this, it is that it's early intervention in high-risk patients. Okay, so how do we select? Who do we select for early invasive treatment? The randomized control trials tells us that early invasive therapy is most beneficial in the highest risk patients. So this is a busy slide, and I just want to take you through it slowly because I will focus on how we identify very high risk, and low risk patients. So patient comes to you with symptom onset, and the first medical contact may or may not be a cardiologist. If you are a non-PCI center, once again, the first thing you do is you risk stratify these patients into very high, or low risk. If it's very high, it's immediate transfer to a PCI center. If it's high risk, then it's within 24 hours to a PCI center. If it's low risk, then you can have selective invasive, and you can base your history on low risk, and you can discharge the patients and refer them for coronary angiography or non-invasive testing, depending on how high or low risk you define these patients. So these are the three categories: less than 2 hours, less than 24 hours, early invasive, immediate invasive, or selective invasive. How do you risk stratify? So patients deemed to be very high risk, you refer for invasive coronary angiography within 2 hours. And I want to take you through the European Society of Cardiology guidelines. Which patients should you be sending for invasive coronary angiography within 2 hours? These are patients with hemodynamic stability, low blood pressure, changing pulse rate, or in cardiogenic shock. Patients who, in spite of optimal medical therapy, are continuing to get ischemic sounding chest pain. Patients with frequent arrhythmias in spite of medical therapy. Of course, if they have mechanical complications such as VSD, mitral regurgitation as a result of the MI, or those patients with significant ST segment depression, or that you feel have pulmonary edema as a result of the ischemia. One or more of these features you refer for urgent, less than 2 hours coronary angiography. What about high risk? How do you define high risk? So these are patients in whom you have made a diagnosis of non-ST elevation myocardial infarction based on the algorithm. These are patients in whom you have dynamic ST T-wave segment changes or new ST segment changes. These are patients who have transient labile ST segment elevation. And as I said at the beginning of the talk, these are patients, if you use the GRACE score, who have a GRACE risk score of greater than 140. If they have that, then you should try and have your facility accept these patients within 24 hours. What about your low risk patients? Well, all those who do not fulfill the first two criteria of very high risk and high risk are by definition low risk. And in these patients, you can have a selective invasive strategy. You can send these patients home, or you can do in-hospital ischemia testing, or you send them home with plans to come in for assessment of their coronary angiogram, either invasively or non-invasively using coronary CT. Once you have identified the patients who are going to stay in hospital, you've performed coronary angiography, you have found significant coronary artery disease, what is your choice of revascularization strategies? Well, they will have gone to a PCI center, but they may not have surgical surgery on site. Certainly in the UK, not all PCI centers have on-site surgery. So which patients should have percutaneous coronary intervention? So I've made a list of patients who are clinically unstable in whom you just do the culprit vessel. Patients who have low to intermediate syntax score. So those of you who are not familiar with the syntax score, this is a score that we can base using the coronary angiogram, and they are in the low or intermediate score or high burden of coronary artery disease. Those with high burden go for coronary artery bypass graft. Those with low or intermediate coronary artery burden or syntax score can have PCI performed safely. The advantage of PCI is that patients can be discharged typically at our institution the following day. You can also assess functional significance during coronary physiology during intervention of other stenosis, and you can assess coronary risk based on age, presence of comorbidities, or left ventricular function. Certainly in the UK, 5 to 10% of patients will undergo CABG when they come in with a diagnosis of non-ST elevation ACS. it is said that the advantage of CABG is that patients can have complete revascularization, but I would say to you that those with lower intermediate syntax score can also undergo complete revascularization following PCI. There is good trial data that patients who are diabetic with complex multivessel disease benefit more from coronary artery bypass graft surgery. And certainly those with multivessel disease, MVD, and left ventricular dysfunction, ejection fraction of less than 40%, trials suggest that they benefit from surgical revascularization. The risk of ischemic events is less than 0.1% if they have surgery, but there is a 10% risk of perioperative bleeding because majority, if not all of these patients, will be on dual antiplatelet therapy. So once these patients have gone to a invasive coronary angiography center that does PCI, the operator then has to decide, do they revascularize just the culprit vessel, or do they perform complete revascularization in patients with non-ST elevation ACS? And the SMILE study gives us a direction of travel in how to treat these patients. So this study reported the 1-year clinical outcome in over 540 patients of a single stage PCI versus a multi-stage. So these were patients who had revascularization at the first stage, and then second group, the 263 group, had a staged procedure. Only 15 patients were lost to follow-up at 1 year, but you can see that the data here, that if you had complete revascularization at the first stage, that your MA, major adverse cardiovascular and cerebrovascular events at 1 year were significantly reduced if you had complete revascularization at the first stage. And it was superior to a multi-stage procedure, i.e. those patients who came back at several weeks later for further events. And this was mainly driven by the unexplained benefit of target vessel revascularization in the first stage approach. So in summary, if you have patients with multivessel disease who've presented with non-ST elevation ACS, we should look to complete revascularize these patients at the time of admission, at the time of coronary angiography. And that's another important take-home message. So the ESC gives a 2AC recommendation for complete revascularization in patients with non-ST ACS. And that certainly is our practice in Newcastle. If you have complete revascularization during index PCI, you can certainly consider this, and it is a 2BB recommendation. If you have fractional flow reserve assessment capabilities, so this is a wire which can look at coronary physiology of the lesions, and it can tell you if a lesion is severe. If you have that, then by all means use it to guide revascularization in your patients. And we can talk about this later. What I want to do on this is that the decision on immediate PCI of the culprit stenosis, I emphasize, does not require heart team consultation. And this is the ESC guideline. So if the patient has stable angina and they have elective revascularization, by all means discuss it with the heart team. But if the patient has come in with a non-ST elevation ACS, the decision for immediate PCI of the culprit stenosis does not require heart team consultation. So it's a lot of information. What I've tried to do is to take you through how we define acute coronary syndromes, risk stratifying the mortality risk, the trial data for early versus late intervention, revascularization of these patients, and when to revascularize. And I want to quickly now just give you a summary of the management strategy of these patients. So this is a busy slide, and once again, it's from the ESC 2020 guidelines, and it's the management strategy. So when patients are admitted with NST ACS, you do a mortality risk score based on GRACE or TIMI risk score. You look at the patient, you look at the ECG and the vital signs, you then make a diagnosis based on risk score, high or very high risk. So if it's very high risk using these factors, you refer the patient for immediate invasive therapy. If they have these risk factors, which I've gone in detail, you have the option of referring to your invasive center for invasive coronary angiography within 24 hours. If they don't fulfill any of these criteria, you can then have the option of in hospital or within 4 to 6 weeks, non-invasive imaging of risk stratification. You then have the option, once they are in a angioplasty surgery center, of deciding whether to favor PCI or CABG. And these are the features that I have gone through in the talk that favors either PCI or CABG, and I won't go through this again. And then once again, I won't talk to you about antithrombotic and optimal medical therapy, because you'll all be familiar that optimal medical therapy is essential for these patients. So what is the take-home message? Lots of clinical trials now have helped to guide how we manage these patients optimally who present with non-ST elevation ACS. And what is clear is that all of us, whether they come into a cardiology center or a non-cardiology center, wherever these patients come, our first role is to stabilize these patients. Our second role is to risk stratify these patients. You can risk stratify for mortality risk, and then you risk stratify for transfer risk to an angioplasty PCI center. The risk stratification is based on the criteria that I've said, and you classify these patients into immediate transfer within 2 hours or transfer within 24 hours or further assessment. What I hope I have shown you, that the available evidence from large numbers of clinical trials, and I've only given you a selection of 6, is that the available evidence favors selective but routine invasive strategy in very high and high risk STEMI patients. So not all, but high and very high and high risk non-STEMI patients. I haven't shown you the data because I thought it would be too much data, but this applies even for elderly patients who are over 80 years of age, because often these patients were neglected, but now the data shows that even for patients over the age of 80, if they are very high or high risk, routine invasive strategy, immediate or within 24 hours is of benefit. Whether it is Sri Lanka, whether it is the United Kingdom, whether it is the US, the network that the hospitals work in, the network system has to be established to transfer your high risk and very high risk non-ST ACS patients for invasive coronary angiography within 2 and 24 hours. Sometimes it's difficult. We find it difficult here to transfer immediately within 2 hours, but you should have a network system. And what I mean by a network is that you have a group of hospitals that don't have cath labs within a network of hospitals that have a cath lab, and that network should work to transfer patients. So that means identifying patients, having a transport system, having sufficient beds and resources to have these patients transferred to an angioplasty center where they can undergo timely invasive coronary angiography. Of course, optimal medical therapy and lifestyle changes remain a gold standard to reduce long-term cardiovascular mortality and morbidity. I thank you for your attention, and I'm open to questions.
Thank you very much, sir. I think we'll kick off with a couple of questions which were actually put to the line. So now you said that in verdict trial that there was no difference in early versus late invasive approach. Was
Yes.
it due to treatment with enoxaparin or with the enoxaparin, because it might reduce the thrombotic burden, so that might reduce the complications during the procedure? Is it the reason, or what do you think?
No, I think when the verdict trial came out and it was done, people suggested that that was the reason. But if you look at later studies, all of them used some form of anticoagulant in this patient population. I think the key thing about the verdict compared to the other studies was that in the studies that risk stratified patients, this is where you found a difference. The verdict trial just identified those patients, randomized them into standard invasive or very early invasive. It did not risk stratify patients. If you look at the study that risk stratified patients, okay, which was FRISK2 and TIMAC, what TIMAC did was risk stratified patients. And what is clear is that the patients who benefit from an early invasive approach are those who are deemed to be high risk and very high risk. The verdict did not do that.
Yes. And in our practice, the most of our patients, actually, if you consider the non-STEMI patients, only 5 to 10% receives invasive coronary angiogram and treatment compared to the STEMI patient, because now we are concentrating more on the STEMI patients, and they receive thrombolysis and actually 5 to 10% will receive primary PCI, and rest will receive thrombolysis, and then out of then the failed thrombolysis patients will receive this invasive coronary angiogram and revascularization.
Yes.
So comparatively, this is the much needed population, acute coronary syndrome, who needs early invasive approach.
Yeah, no. So I think you have to base it, Roshan, on the resources that you have. And what you have to do, as I've said before, is that you have to create a network of hospitals, those with invasive facilities, linking in with those without invasive facilities. And of course, you can only perform early invasive and non-selective invasive once you have delivered your primary PCI program.
Yes.
Thank you very much, Professor. I would like to ask one question from you. Would you like to elaborate us on the duration of dual antiplatelet therapy following after the stenting? Because, you know, recently the terms came out as extended dual antiplatelet therapy, as well as the modified, as well as shortened. So would you like to elaborate us on that?
Yeah. So let's be very clear. The shortened refers to patients who present with stable angina and have elective PCI. So that has now changed to a maximum of 6 months. If we're talking about acute coronary syndrome, remember, we're talking not just about endothelialization of the stent, but we're trying to reduce ischemic event rates. So in these patients who present with acute coronary syndrome, the minimum recommendation is of 12 months dual antiplatelet therapy, because we're trying to reduce ischemic events. In the acute coronary syndrome population, we now have extended therapy. So there is a group of patients, and I use the Pegasus TIMI54 trial data to identify patients who are at high risk of ischemic events. So these are patients who've come with a second ACS event, patients with diabetes, patients with multivessel disease, patients over the age of 65 and patients with chronic kidney disease, if they have 2 out of those 5, I will extend their dual antiplatelet therapy to up to 3 years with low-dose ticagrelor. So to summarize, shortened duration in patients with elective PCI for stable angina. All patients with ACS, a minimum of 12 months of dual antiplatelet therapy. And some patients with acute coronary syndrome who are at high ischemic risk, extended therapy for up to 3 years. And the extended therapy can be with clopidogrel, if that's what you have. We use low-dose ticagrelor, 60 milligrams BD. And in patients with peripheral vascular disease, we will add in a low-dose 2.5 milligrams BD of rivaroxaban.
Yeah.
Thank you.
And there's one question from the audience. Is there any cutoff value for high sensitive troponin to consider high risk versus low, the other categories?
So not necessarily for defining high risk. So what the troponin does is tells you whether it's an acute coronary syndrome. But once you have made that diagnosis, then we use clinical features to define high or very high risk, as I've explained in the talk, but not using troponin makes the diagnosis of non-ST ACS or not.
Yes.
Okay. Once you have made the diagnosis of non-ST elevation ACS, you then use clinical and ECG features to determine high or very high risk.
Thank you, Professor. We have another question from the audience. A guideline shows AVR ST elevation as end-STEMI. When to consider AVR ST elevations as STEMI needing thrombolysis?
Yeah, I mean, that's a very, very good question. So we can talk about guidelines. And what I always say to my juniors is that guidelines apply to 80% of the population, 80% of the time. So that leaves about a third of the time where you have to use your clinical acumen and your clinical judgment. ST elevation in AVR, Roshan will know this, typically signifies often left main stem or severe multivessel disease involvement. And in those patients, I would define as high and very high risk and transfer for invasive coronary angiography within 24 hours, regardless of troponin. The other extreme is when you see a 45-year-old male who has had one episode of chest pain, will have low troponin, but have anterior deep T-wave inversion. So using the criteria that I have said to you, you would not put them in the very high risk, but you know that clinical judgment tells you that this will be a proximal LAD occlusion. So when you use guidelines, you mustn't lose sight of clinical judgment and clinical experience.
Yes. Actually when we do intervention, especially in acute coronary syndrome, non-STEMI, sometimes Professor, we see no reflow after stenting. So in those instances, if there are any other vessels in the patient is stable patients, do you recommend us to proceed with stenting the other vessels?
No, I think, Roshan, you know this, that I think most interventionists, if you get slow flow or no flow, then typically it's a sign of a big infarct. And the recommendation, although the trials don't say whether they had flow, the recommendation would say go on and revascularize the other vessels because these patients have the best outcomes. But I think most interventionists would stop and bring the patient back if they haven't got a perfect result in the culprit vessel.
Yeah.
Professor, we have another question from the audience. What is the value of troponin rise or troponin drop in 6 to 12 hours? Is there a place of repeating troponins?
So if you have a rise and fall, that is very, very strong marker of non-ST elevation ACS. Okay, assuming there is no associated ST elevation. If you have the rise and fall, you can make that diagnosis of non-STE ACS, and you then don't have to repeat the troponin. So the rise and fall is very important. The ESC suggests you do that within 3 hours. At 6 to 12 hours, if the patient has delayed coming in, you have a level, and if it, of course, it has to be married to chest pain, to ischemic chest pain. If the troponin continues to fall, then that is suggestive of a myocardial injury, and I would treat that patient as non-ST elevation myocardial infarction.
Thank you, sir. Another question from the audience, sir. What about the thrombolysis in patients with De Winter's ECG?
With?
De Winter's ECGs.
Okay. My personal feeling is it will be dependent on cath lab access. My personal feeling is that if you have this, they should go to the cath lab.
Thank you, sir. Another question, if you have time, how to approach in a patient with chest pain presenting with left bundle branch block?
Yeah, that's a very, very good question. So my personal feeling is that when you have a patient with ischemic sounding chest pain, that overrides everything. So this patient, if assuming their troponin is raised and they have ischemic sounded chest pain, they should go once again to the cath lab if they're in the high, very high risk category. If they don't have ischemic sounding chest pain without and no troponin rise, then I think they should have non-invasive testing at a later date.
Roshan?
Yeah, I think there are no more questions. Do you see anything, Disna?
This is Arosha. Is it possible for me to ask a question?
Yeah, sure. Yes, of course.
Yes. One is I'm very grateful to Professor Zaman for, how shall I put it, an erudite but a very lucid lecture. I mean, it was like very, very clear. So I'm really, thank you very much for making maximum use of the 40 minutes and making a very clear presentation where everything is so crystal clear. I just have one little question that I have is the meta-analysis that you presented, Professor Zaman, showed that all-cause mortality did not improve with early interventions, but the cardiac outcomes did improve.
Yes.
So I'm just wondering what could be behind this discrepancy, because I would have expected, because most people with after an MI, we would expect them to die from a cardiac disease. Yeah. And then of course that should bring down the all-cause mortality as well. Is there any explanation for that?
Yeah, so my own feeling is that the follow-up is not long enough to show that. So when you look at data that have followed patients up for 15 years, and there's a really good observational data following patients up who have had undergone invasive therapy, that you really start to see the effect of mortality at around the 10-year mark. Most of the studies follow patients up around 3 to 5 years, and what they do, they give a composite of major adverse cardiac and cerebrovascular events. and you use the composite of events to show a difference, but you're absolutely right. There is no difference in mortality. So I think one is the length of follow-up, and the second, I think the secondary prevention strategy that we are currently using with antithrombotics, anti-lipids, beta blockers, ACE inhibitors, I think have had a remarkable effect in reducing mortality in these patients. Second, early intervention also, in my opinion, has had a favorable impact on left ventricular function. And by preserving left ventricular function, I think it may have helped to delay mortality until beyond 5 years. So on multiple reasons, but as an interventionist, I would say to you that selecting the right patients to go to the cath lab has reduced events. And if we follow these patients up for longer, I think you will see a benefit in mortality.
Right, thank you very much. One more. Now, for diagnosis of a very high risk patient, there is no place at all for the GRACE risk assessment. From what I gathered, it comes into play only in identifying risk, not it's mortality not there for the very risk. High risk, but its mortality risk is very high. There is no Correct. Place for GRACE, but it comes in only for high risk and then of course low risk. So that's interesting because, yeah.
Sorry,
please, please.
No, so yeah, I wanted to define that there's a mortality risk which you can make for your patients pre-discharge and on admission. So GRACE score will tell you about the mortality risk within hospital and at 6 months. Then there is the risks that you calculate for the timing of invasive therapy. Two different risks. Yeah.
Thank you. That you've made it very clear. Thank you. There are two different risks and we're talking about here.
Yes.
Okay. But of course, GRACE comes into intervention risk also when it comes to high risk category, more
Correct.
than 140.
So, correct. So if you have GRACE risk of greater than 140, these are deemed to be high risk and they should have angiography within 24 hours.
Thank you. And then you mentioned very briefly the word. I thought that was very interesting to assess the risk of mortality as well as for a non-PCI center, as well as the risk of transfer. You mentioned that. I'm just wondering, I have no idea how a physician who is working or a cardiologist who is working in a non-PCI center could possibly assess risk of transfer. Do you have anything that you could explain to us, please?
So once again, I was trying to make the point that the risk for transfer is based purely on ECG clinical signs and symptoms. So number one, if you're working at a non-center, optimal medical therapy is the first and foremost. And I think there's a question about not having cath lab facility within 2 hours. And of course, this is a major limitation. So what the non-cardiologist working at a non-invasive center should be doing is optimally medically treating these patients and then defining these patients as either high risk or very high risk. And what I would recommend is that once you have made that definition, the patient should not be discharged until they have had invasive coronary angiography at a PCI center.
One final question. Why did TIMI fall out of favor and what's the advantage of GRACE over TIMI? Well, why did this paradigm shift occur?
So looking at trials, if you look at all of the trials in its entirety, what the TIMI and GRACE did was that on a population basis, it was very, very good. So if you wanted to look at 1,000 patients, by and large, the third of patients that had GRACE score over 140, by and large, they would do well. But on an individual patient basis, none of the risk scores were deemed to be very good, and therefore they have fallen out of favor for more individual scoring system based on clinical risk and ECG, which also determines their risk of transfer. So what was happening was that, let me give you the example. You have a 45-year-old male who comes in with either a de Winter's ECG or T-wave inversion anteriorly. The Grace risk score is very, very low. Yet, because of recurrent chest pain, they should be transferred as high risk or very high risk. So what the Grace score was doing, in the opinion of the guideline makers, it wasn't giving an individual patient basis for transfer for invasive risk. And this is why the Grace and the TIMI have fallen out of favor, certainly amongst interventionists.
That's a beautiful explanation. How it applies to the individual and how it applies to the community. For the community, Grace and TIMI would be ideal, but for the individual, the ESC guideline risk assessment would be what really counts. Thank you. That really explains everything. And from an administrative point of view, I think the take-home message for all of us here in the audience is the point that you emphasize, that we need to build up a system in which we will risk stratify for mortality and have a network of transferring the patient to the appropriate center at the appropriate time. I think that seems to be the national priority.
Yes. Yes.
Thank you so much. I have nothing more, no more questions to ask. Everything is very. Again, my heartfelt gratitude to you, Professor Zaman, for a beautifully constructed lecture. Thank you so much. Over to Roshan and Disna to continue any more questions and conclude the discussion. Thank you once more.
Thank you, sir. I think the main important thing is, as we have limited resources as a practicing physician, because you all are managing most of the non-STEMI patients. So please select the patient who desperately need invasive angiogram and intervention. Please select them and refer to the interventional center. So that's very important message from Professor and Dr. Arosha. Yeah, are there any more questions to be?
I think due to the time factor as well.
Okay, then let me conclude the session. Professor Azfar Zaman, dear sir, I thank you on behalf of Ceylon College of Physicians for taking your valuable time from your extremely busy schedule to be the guest speaker today. I understand you are doing the CAS session now, and you must be doing the acute lab, hopefully. So when to intervene in non-STEMI, I think this would be an eye-opening session to all internal medicine physician in Sri Lanka. And also I look forward to seeing you in Sri Lanka at Sri Lanka College of Sessions annual academic sessions in 2022 this year. I also thank President and Council of Ceylon College of Physicians to arrange online session with international renowned speakers to uplift the knowledge in current practice in colleagues in Sri Lanka. Finally, I would like to thank all online participants who joined the session despite their busy schedule and with a great interest. Thank you, everybody. Good night.
Thank you, everybody. Good night.